everybody. Welcome to the presentation. Our speaker today is Sarah Walters. She is an HPCSA registered genetic counsellor and medical scientist. She currently holds the position of principal genetic counsellor at Ampath Laboratories. She has over 20 years of experience in counselling clients in various genetic conditions, from prenatal to post-natal, late onset disorders, and cancers, amongst others. She's also involved in lab work analysis in sequencing and arrays CGH. She has a particular interest in educating other healthcare professionals in human genetics and the intricacies of new genetic testing and their applications. She brings teaching and mentoring expertise from instructing medical students at the University of Witwatersrand. She's also currently in training co-ordinator for intern medical scientists in genetics at the NRL Genetics Laboratory. She serves as an assessor, moderator, and site assessor for the HPCSA. She has also presented at many local and international conferences. She has worked extensively in both state and private with children, adults, and families with cystic fibrosis. And she has currently submitted her PhD. So we're very privileged to have you come to give us another presentation. We really appreciate it.
Thanks so much. And sorry for the boring title, but I thought, you know what? As a genetic counsellor, what I do is break things down into manageable chunks, manageable pieces, and nothing more plain than genetics of prostate cancer. So I was thinking about doing breast cancer genetics, but I think that we've heard that quite a lot. There's always new information to learn. So hopefully in the future I'll be able to do a breast cancer talk as well. But I was recently asked about the genetics of prostate cancer from an oncologist, and this is something that we've never really dived into because we always associate prostate cancer with a family history of breast cancers. And so they seem to link and go hand in hand with each other. And so looking at the genetics of prostate cancer, I wanted to know if there were any specific genes that were relevant to prostate cancer that we might not think about if we are just concentrating on family histories related to breast cancer. So as I usually do, I just want to remind you of the basics. And this is all part of my PhD in reminding healthcare professionals where we start off with the genetics. A karyotype, this one's got 46 chromosomes, which is normal, and it's an X and a Y, meaning a male individual, obviously chosen because of the prostate cancer today. So chromosomes are made up of DNA. The DNA is tightly wound into these structures called chromosomes. And what we need to remember is that we inherit one chromosome of each pair from each parent. So one from mom and one from dad for each of the numbers. And then obviously when you get to the sex chromosomes, the X comes from mom and the Y comes from dad. So when we're tracing lineages or doing paternity testing, the Y chromosome is very important for us in terms of tracking Y chromosome inheritance, so from men to boy children. Okay, this is what I was talking about in terms of chromosomes, and then unwinding. And remember, there's histones and all sorts of other proteins that get in order to wind up the DNA very tightly in order to be able to fit into a cell. And then a certain region of a chromosome is called a gene. And a gene, I always describe to patients, is very much like a recipe. So a recipe for making a chocolate cake or a recipe for making spaghetti bolognese. You have a starting point where you have all your ingredients, and then you have your instructions all along until you get to the stop point, and that's when your recipe is finished. And therefore, the gene is responsible for making an enzyme or a protein or some kind of instruction that the body needs in order to function correctly. So we have around about 20,000 different genes spread across all of the chromosomes. And remember, just like we've got two pairs of genes, two of every chromosome, we've also got two of every gene. So a lot of patients do come in and they ask if I've got the BRCA gene. And I say, well, yes, you do. In fact, you've got 2 BRCA1 genes and 2 BRCA2 genes. The question is, are they working properly or not? Is there a change in the gene sequence that will cause them to make a faulty protein or to not make a protein at all? So when we have a look at our DNA, we understand that our DNA gets damaged all of the time. So whether it be by sunlight, by radiation, by toxins that we ingest, pesticides on our food, and stress. Stress is becoming a big area of investigation and causing DNA damage. So when we have DNA damage, we rely very much like having DNA damage repair mechanisms. And so if we have a look at all of the proteins that are involved in DNA damage repair, the ones on the left I have put, I think you will probably recognize most of these. So BRCA1 and 2, obviously, ATM, PALB2, that's the partner and locator of BRCA2, CHEK2, and this was the gene that I was most interested in, the HOXB13 gene, because that isn't a gene that we come across on a regular basis as far as breast and ovarian cancers are concerned. I didn't touch anything. So if we have a look at the diagram from Medscape, we can see that BRCA1 is really central to a lot of the DNA repair processes. We go over here, we look at ATM. We're looking over here, we're looking at the BLM gene, which is an autosomal recessive gene for Bloom syndrome. And Bloom syndrome is characterized by DNA breakage. We've also got the MSH2 and the MSH6 genes, and those are typically involved in colon cancer. So those are the MMR genes. I don't know what's happening. I don't know why I keep flashing. Here we go. Okay. If we have a look here, we've got CHEK1, we've got P53, which we know is very important in causing apoptosis of cancerous cells. We've got BRCA2 over here, FANCD2, the RAD51s, and all of those are involved with DNA repair. BRCA1 over here associates with BARD1. So lots and lots of different genes in the pathway, and the DNA repair mechanisms that are used are the homologous recombination type of repair. Only one type of DNA repair over here, which is the non-homologous type. So anyone remember how DNA gets repaired? Okay, blank faces on this side. So we've got 2 types of DNA repair, the homologous and the non-homologous. And so the non-homologous DNA repair is when you get breakage and then you get the ends that need to be joined back together. And all of that is mediated by the BRCA1 gene. So that's when you have a double-stranded break. When you have a look at the homologous recombination DNA repair, that is using its gene partner or the other chromosome of the pair in order to correct the gene sequence. So, and you can see that BRCA1 is also vital in that whole repair system. I'm not going to go through all the technicalities because there are lots of words I haven't used for a very long time. So I thought that it was very complex, and what's important to remember is that it's mediated by a lot of different proteins along the pathway in order to get a correct sequence of DNA. So the way that I explain this to patients as well, and I think it's simple, but it makes sense to them. So when we talk about DNA repair, I talk about you're driving your car along the road and your fan belt breaks. And now you're driving a Toyota and you take it to the Porsche garage, but the Porsche doesn't have the correct fan belt for your Toyota. So it can fix it, but it's not actually fixed in the right kind of way. So your car still doesn't work properly. So only if you take it to a Toyota garage who's got the right spare parts, then you can fix your, the fan belt properly. So that's how I explain it to patients, and I think it just makes sense in that kind of way that either it gets repaired correctly or it doesn't get repaired correctly. And if it doesn't get repaired correctly, that DNA sequence that is incorrect from the incorrect repair, that stays in that cell. And remember then, your cells will continue to replicate. So they divide and they make more cells of the same type. And when you've got more and more and more cells of the same type, all with a fault in the DNA in them, that is eventually how tumors form. Okay, and it can happen in one particular cell type, or it can happen in several different places. So, yeah, just a quick analogy of how I explain DNA repair. When we have a look at DNA damage, we have to be clear about the distinction between the somatic genetic testing and germline testing. Because germline means that you are looking for a pathogenic variant, which is the new name for a mutation. And we're looking for an inherited type, which means that it is present in every single cell in the body from birth. So you've inherited it from a parent, and it's present everywhere. Even if that faulty gene does not have to make a protein in all the different tissue types in your body, it's still there in every single cell. And that is why when we do germline testing, we can take peripheral blood, and that is where we will find the faulty gene. So when we look at germline variants, pathogenic variants, there are now more and more treatments available that are quite specific for a gene, or maybe even specific for a type of pathogenic variant. So if you cast your minds back to the types of variants that occur that can create a mutation, we have stop codon mutations, we have substitutions, we've got all the point mutations that change it, we've got missing pieces of DNA. So lots of different ways in which the DNA can remain damaged. And so the treatments that are becoming available either will be specific for a gene, or they will be specific, for example, for a premature stop codon mutation. And the germline variants that we are looking for, the genes that we're looking for, are usually the tumor suppressor genes. So tumor suppressor genes are, remember, we've got pairs of genes. You can inherit one faulty copy of a gene, but you need further damage to the second copy of that gene in order to be affected. I do have a slide later on, so I'll explain that better. When we're looking at somatic testing, we're looking at the tumor specifically that is affected, and we're looking for what we call acquired genetic changes or variants within the tissue itself. And this is also used to plan treatment, but the genes that are involved in these are called oncogenes. So the normal structure of an oncogene is actually called a proto-oncogene. And a proto-oncogene, as long as it works properly, is enough for you to be okay. But it's when the proto-oncogene acquires a pathogenic variant, it becomes an oncogene and therefore doesn't work properly. So yeah, here we've got the classic oncology diagram. So I've never been to an oncology lecture without them showing some kind of racing car. And it's really a good analogy of how we look at the genes. So we've got the accelerator, which is the proto-oncogenes, and we've got the brakes, which are the tumor suppressor genes. So if we have a proto-oncogene that acquires a fault, it's like having your foot on the accelerator of the car and you can't stop the car. Your accelerator is stuck in the down position. And so it continues making abnormal cells that all have this fault, this oncogene, the fault gene in it. And so that is what will lead to cancer. However, if we look at the tumor suppressor genes, it's like having no brakes in the car. So your car will just carry on driving developing more and more cells with the pathogenic fault, and will then turn into cancer once we have what we call a second hit. So the second hit, let me just move these slides along. Okay, I have not got them in the right order, so it's fine. We'll just continue with this one. So this is an example of a somatic mutation where we've got two particular genes on chromosome number 21 at 22.3. We've got the ER gene, and we've got the TMPRSS2 gene. Now, these two genes actually sit 2.7 megabases apart. But the fault occurs when there is DNA damage, and these two genes, the DNA in between them is damaged or is cut out, or some kind of damage happens to it. And therefore, the 5' end of the ERG, which is the beginning end of the gene, and the 3' end of the TMPRSS2 gene, they join together. And then it becomes read as one gene. And because it's not supposed to be, we don't have a proper end point to the TMPRSS gene, and it continues transcribing into the ERG gene. So what happens is that we have an overexpression of this fusion of two different genes. And this is what FISH, so I'm sure you've heard of FISH, fluorescent in situ hybridization. This is what a fusion gene could look like when we have a look at it under the fluorescent microscope, is that you've got the 5' ERG, which is in green, and the 3' is in red, where the TMPRSS2 gene is in light blue. And so what you are seeing is an amalgamation of the three colors here. So that creates one gene. If we have a look at interphase signals, so this is obviously a metaphase. We can sort of identify each chromosome. I dare you to do it, looking at the karyotype like this. But when we have a look at, so what we try and do is do 10 interphases so that we can, 10 metaphases, sorry, so that we can have a look at the actual chromosome, the chromosome 21, where the fusion has occurred. And then we look at lots of interphase cells, because the interphase cells are more abundant and easy to score. So we can see over here that there's a fusion. So those three signals that are supposed to be apart. So remember that the green and the red one are on the same gene, but the blue one is on a separate gene, even though it's on the same chromosome. So we're looking for fusions that occur all of the time. And you can see the normal signals that are separate from the others of the other chromosome, number 21. Is that clear? As mud? Yes? Okay. All right, here is another nice one to have a look at in terms of c-Myc, which is a transcription factor. And so what happens is that it causes tumor proliferation. So what happens when testing by FISH is we've got the 5' end of Myc, which is in red, and the 3', which is in green. And so what you can see here is that the actual 5' end of the Myc gene has been amplified. So now we've got lots and lots and lots of red signals at 5', but very few green ones at the 3'. So you can see the two green signals, but you see lots and lots of red ones. And then also in these interphase cells as well. And this is exactly when we're testing for breast cancer, this is exactly what the HER2 signals look like as well. If you've got amplification of HER2, you have lots and lots and lots of red signals in a cell. And it shows you the amplification of that part of the ERBB2 gene, I think it is. Okay, so testing of tumor tissue is done by what we call the Oncomine Comprehensive Array. And what this assay, what this does is look for copy number variants. So it's looking for extra and missing chromosomes. It looks at coding sequences that codes for a protein. It can also measure tumor mutation burden. And then it can look for particular hotspots. So sometimes we know that we don't need to sequence a whole gene, that there are particular hotspots within a gene where the DNA damage occurs most of the time. And then we look for gene fusions as well. So intragenic, so in other words, a piece of the actual gene missing, or intergenic, mean two separate genes that are fused together that create the cell proliferation. And so some of the genes that we have a look at in somatic testing are BRCA1, BRCA2, and all of these I think will look familiar to you. ATM, PALB2 I've mentioned, FANK-A, anyone know what that's for? Fanconi's anemia. Yeah. Okay, so And then RAD 51D. So in our germline panel, we actually test for RAD 51C and D, CHEK2 and CDK12. So all of these genes have been identified as having pathogenic variants in metastatic prostate cancer. And we also need to think about the mismatch repair genes, such as those from Lynch syndrome. So the MSH2, MSH6, MLH1, PMS2, and we can do MSI testing on them, or we can do immunohistochemistry on them as well. And so, as I said previously, testing of the somatic tissue is really important because there might be specific therapies that are related to a pathogenic variant in that particular gene. If we have a look at the germline testing, it's pretty similar. I always put this picture up for breast cancer, but it's pretty similar to what we quote for breast cancer in terms of 5 to 10% of prostate tumors are hereditary. And so what happens is that a pathogenic variant is inherited and it increases the risk of developing cancer. So just because a patient has got one faulty gene, it does not necessarily mean that they definitely will get cancer, but there's an increased risk of them for getting cancer. And then having a look at the genes helps with treatment, response, and it also helps with prognosis. And by identifying a germline pathogenic variant, it gives us an opportunity to determine the cancer risk for relatives. So that especially will go for siblings who are at 50% risk of inheriting the same pathogenic variant, and then also children of the patient who will also then be at 50%. The germline testing for prostate cancers are recommended when they are highly metastatic or there's a high risk of prostate cancer because of a family history. So in prostate cancer family histories, first, second, and third degree relatives with breast cancer that developed below the age of 50 years, ovarian cancer, pancreatic cancer, metastatic high or very high prostate cancer, and individuals from the Ashkenazi Jewish ancestry, because we know that there are certain pathogenic variants in certain genes that are more common in certain population groups. And then also if in the family there's somebody who has developed colorectal cancer below the age of 50, and then a uterine or endometrial cancer below the age of 50. So you can see that there's so many of these different types of cancers that are related to the same set of genes when we're having a look at prostate cancers. And a known pathogenic or likely pathogenic variant in a susceptibility gene in the family is going to give us a lot of information on how to manage people at risk in terms of starting screening at an earlier age than you would do in the general population. So, for example, the general rule is that if there is, so you look at your family history and identify the earliest onset of cancer in the family. So say, for example, that was at 40. Then what we recommend is that we start screening for cancers at 10 years before the earliest onset of cancer in the family. So testing at 30, sure, if it's something like a PSA that you're doing, so then that's fine, there's no damage. But I think that when we're talking about mammograms, we need to be careful about how early we start looking at them. But in saying that, I have had families where there's been a 25-year-old and a 28-year-old diagnosed with a breast cancer. So I think you just need to use discretion about when you start screening. And this is me. I think I showed this picture last time, 25 years and 25 kilograms ago, when sitting, chatting to a coloured mum who had a baby affected with albinism. But collecting a family history is really a good way of connecting with your patient and talking, because only they know about their family history. So talking for them to talk about their family history starts off a counselling session by getting them to feel comfortable, giving you the information that they know. So the genetic counsellor, what we do is collect the family history, Identify an index person to test. So this might not always be the person that comes to see you. So if they are, for example, not affected with a cancer, or there's another person in the family that has got a cancer, plus their children, plus their siblings, whoever they are in the family, that might be a better person to identify for testing because you're more likely to find something in that person. So part of our role is education, counselling, and then going through why has the patient come to see you? What are their objectives? What do they want to know from you? How can you help them? So what are the benefits? And we go through the benefits and the limitations of testing. Some people decide not to test if it's a predictive test, and that's okay. I think as doctors, we think, don't you must test, you must have this information, but it's okay not to know, because if they've been through a horrific family history of lots of cancers, then they maybe would rather not know, but maybe start screening earlier. And so informed consent, we were talking about ethics this morning, informed consent is really important in discussing all of these benefits and limitations and how much they understand. So a testing panel for prostate cancer must include at least these 6 genes. And this is the minimum. So I was looking at the NCCN guidelines as well. They recommend a whole lot more, which I'll show you just now. But BRCA1 and BRCA2 are classic in the family history where we have breast ovarian cancers, and then we've also got prostate cancers in the males. And then obviously the MSH2 and the MSH6 are related to Lynch syndrome. So this is when I had a look for a typical family history of prostate cancer. We've got here 3 generations where there's prostate cancer in all the males. And I must say, I have never come across a family that looks like this. They're always much more complicated. So we've got prostate cancer at 72, 74, 74, 65. And now you'll see in the next generation down, we have an earlier onset of cancer. And this we find often in families where there's the possibility of an inherited type of cancer, is that the cancer will start at an earlier age. So we've got a male at age 49 was diagnosed with prostate cancer. And so now here's your index person over here. Here's the person that came to see you because of this risk of prostate cancer in the family, and therefore testing his father would be the appropriate person to test to see if there's an inherited pathogenic variant in one of the prostate cancer related genes. This is one of my patients' families who came to see me because of because of this man over here. This man over here. Here is a male who was diagnosed with breast cancer. His twin brother had prostate cancer, and I can't see what else.
Bladder.
Oh, it's a bladder from here. I'm sitting too far back. 2 sisters with, I think, breast cancer. And then look at the aunts up here. I think they're all basically breast. The other one might be an endometrial.
Lymphoma.
Oh, lymphoma. Okay. And then the others, I think, are all breast. So when you see a family like this, and this is a real family, by the way, this is a family I have seen. You've got lots and lots of diagnoses. You don't have a lot of males in the family that are, the direct relations. So you've only got the one brother over there in the 2nd generation, this one over here, whereas the rest in the family are females. So it's going to be difficult to pick up whether this is a prostate cancer family or whether we call this a breast cancer family. But we know that the twin brother had prostate cancer, and then a male with breast cancer is obviously an unusual finding. And when we did genetic testing on this man over here, we found a common Afrikaner pathogenic variant in the BRCA2 gene. And so this is what was causing the cancer in everybody over here. So having a look at this man's children, one of them had passed away, I think, in a car accident, and then there was a female that was still alive. We tested her for the same pathogenic variant, and she was found to be a carrier. So she was not affected at the time, had not developed cancer, but she's at an increased risk of developing cancer, up to about 85%. Okay, and this is the slide that I wanted to show you earlier in terms of how do sporadic cancers form and how do germline cancers form. So when we are having a look at the sporadic cancers, we have a look at the bottom part of the diagram here. So all the somatic cancers. These are the ones that occur specifically in a tissue. So we are born with two normal functioning genes, and we live for 10 or 20 or 30 years, and we get DNA damage to a particular tumor suppressor gene that does not get repaired properly. And so therefore, the cell will continue dividing, making more cells just the same, but now all of them will have this DNA damage in them. And you live for another 20, 30, 40 years, and then finally you get another incident of DNA damage to the second variant, to the second gene, and now you've got neither of these tumor suppressor genes working, and this is what then leads to cancer. So when we are having a look at the inherited type of cancers, what happens is that we've already got one faulty copy of the tumor suppressor gene that is present in every single cell. And so you can imagine, you can see only one change over here. So if this is 10 or 20 or 30 years, you can imagine that you get a second hit that knocks out the second tumor suppressor gene, and now this is what leads to cancer. So when we're having a look at inherited types of cancers, we are aware, we ask questions that make us aware of how old was the person when they were diagnosed with cancer. Because what you will find in the inherited types is that you will have an earlier onset of cancer in that family. And like I said, in the other family tree, it can occur earlier in the family as well. So we've got now two hits at an earlier stage. We have also got certain population groups that are where certain variants and certain tumor suppressor genes are more common than in other groups. So Afrikaner population and Ashkenazi Jewish population are the two that we concentrate mainly in South Africa. We haven't found any common pathogenic variants in the BRCA1 and 2 genes in the Caucasian population, in our South African Black population, or in our coloured population. So, or Indian population. So I was involved in breast cancer review of all of the variants that have been found in an article published a couple of years ago. And there are just so many different variants that can cause breast cancer. It's just phenomenal. So these are the types of, this only when you've got two hits, in other words, two tumor suppressor genes that are non-functional, then this is what develops into cancer. And the other thing that we look for is cancer in paired organs. So I know that prostate cancer is not a paired organ. I don't know where the other prostate is, but anyway, but when you're talking about breast or ovarian, you can imagine that we've got paired organs and that you get two primaries, one in one breast, and then 10 years later in the other breast, two primary cancers are indicative of an inherited. So this is what a typical report might look like, where we've got a BRCA2 change. It's in exon 17, so that just tells us where in the gene it is. And then if we have a look at the nucleotide, we always report on the copy DNA. So the copy DNA at this particular position has got a deletion of a base pair of G. And this creates an amino acid. So the protein is an arginine at position 2645, and it causes a frame shift. So because our DNA is read in codons, which are bases of 3, we get a frame shift, which then probably causes a downstream premature stop codon, and it is classified as pathogenic. I'm just trying to get the slides to move. Okay, so on our requisition form, so this is specifically for breast and ovarian, but you can see that we've got 4 different types of testing that we have available. We've actually got 5 now. We've just changed our request form. But at the bottom here, you can see the cancers that are most commonly involved in causing breast, ovarian, and prostate cancer as well. So all of these could be tested all at the same time on a 9-gene panel. And if none of those are appropriate, or if we test that and they're all negative, what we can do is test overseas. And this is a primary panel specifically for prostate cancer. So these are the genes specifically involved in prostate cancer. And I think the HOXB13 gene is on there as well. Okay, so the normal BRCA genes, ATM, and then we've got our Lynch syndrome, MLH1, MSH2 and 6, and PMS2 as well. TP53 we know is the controller of all.
So I just want to ask, your initial requisition form,
Hmm.
you do indicate which racial group you are.
We do.
The panel that you do, does it cover all racial groups' common abnormalities or not?
Yes, so if we go back to this one, we do ask for the ethnic group.
Yes.
And the reason for that is that if someone ticks, for example, an African patient,
Yeah.
but then they tick the founder mutations, this is an inappropriate test
Yes.
for someone from African ancestry.
Yes.
So in that case, what we do is that we contact the doctor and we say, this is an inappropriate test because of this. Can we rather suggest either this one or this one? And then we ask them about the family history and what's going on. Is this any person affected in the family? So by asking around the family history, age of onset, all of those types of things of the cancer, we can better advise the requesting doctor as to which is the most appropriate panel. So if, for example, Afrikaner is ticked and we look at the founder mutations, then that's fine. We're looking at the most common pathogenic variants found in the Afrikaner population.
Because my frustration is that, you get certain racial groups that come in, for example, with aplastic anemia. You've got the FANC genes as well,
Mhm.
and they test for 1, 2, 3, which are common in South Africa, but this person may not necessarily be of that racial group, or
Right.
the FANC gene that's affected may not be the one that they are testing for. And it becomes a
Okay.
bit frustrating because we're quite a diverse,
We are, Yeah.
population group,
we are.
but we are not catering for all the different
All of them,
population
yeah.
groups.
So I think, and forgive me, but if we have a Johanna Jacoba Maria van der Merwe, I think that we likely looking at Afrikaner ancestry.
Yeah.
And so therefore we would only test for FANC A,
Yes.
because FANC C and FANC G have not been found in people from Afrikaner descent.
Yeah.
However, there is a space here for other.
Mm.
So if you say other and say mixed, and please test for FANC A and FANC C and G, first of all, it'll be very expensive, but you want to try and cover as much as possible. And so what they're doing is that they're covering the common mutations. However, if you want sequencing, then it's possibly better. If you want sequencing of all the genes, it's possibly cheaper to go overseas for that testing, which we will facilitate. Yeah, good question. All right, so we're looking at the germline gene panel for prostate cancer. And remember that whenever any variant is found in any of the genes, the variant needs to be classified into one of these 5 categories. And over time, these categories, the classification of the variant might change. So sometimes, like at the moment, we've got a couple where we've got a variant of uncertain significance, and we don't know. So what that means is that there's not sufficient evidence worldwide for us to know whether it is causative or not causative of the condition at the time. But what can happen is that this VUS can get reclassified either to likely pathogenic, if there's more evidence that's saying it's definitely related to causing the condition. But around 80% of our VUSs get reclassified to likely benign. So we can't say, and no clinical decisions should ever be made on the basis of a VUS. You can't decide on treatment based on the VUS. You can't decide on not treating based on the VUS. The VUS just has to sit until there is enough evidence for reclassification, and therefore treatment will then depend on clinical and other pathology. So it's an unfortunate, but yeah, I mean, we just don't know what all of the variants are in our however many trillion base pairs we have of DNA. So we can't account for all of them. And like I said, there are certain places where there are what we call hotspots, where certain pathogenic variants occur more frequently. And in the HOX13 gene, the HOX13B, I can't remember which way around it is now, there is a pathogenic variant that is common in people from European ancestry, but not from Black ancestry. So that is a reason also that we need to be aware that are we doing the correct test for the correct population group as well. And then in post-test counselling, what we do is that we explain what the pathogenic finding is. We explain risks of cancers to other people in the family. Like I said, siblings and children would be at 50% risk if there's a tumor suppressor gene pathogenic finding. And then sometimes we talk about therapeutic implications. So we don't treat, as genetic counsellors, we don't treat. And as pathologists, we don't treat, but we know there are treatment regimens that are available for certain genes. And so we talk about them briefly in terms of if you've got a BRCA1 or a BRCA2 pathogenic variant, then PARP inhibitors might be an option for treatment. And like I said, there are new medications coming out all the time that are specific either for a gene or for a specific type of pathogenic change. So, for example, there was, I know I'm going back to last time, but in cystic fibrosis, there's a particular medication that if you have a premature stop codon, the medication will jump over that premature stop codon and continue reading the messenger RNA to create a protein. That medication was originally designed for Duchenne muscular dystrophy, not for cystic fibrosis. So that's why I'm talking about particular types of variants that the medication can be used for, no matter which gene it's in. And cascade screening means testing people who are at risk, at 50% risk, and maybe even those people that are at 25% risk. So maybe there is so your patient who you identified a pathogenic variant in, their sister has passed away, but that sister's children can be tested because we aren't able to test the sister. And then these are just our contact details with a lot of our ethics and how we counsel patients and counsel families. Sometimes we've had up to like 6 or 8 people in a very small counselling room, but the whole family wants to be in on it. They want to understand what's happening. I've also had a situation, I think it was in a breast cancer situation, where I had the mum and the dad. I had, I think, 3 sisters, and then there was another 2 sisters on the phone at the same time. So all of them were hearing the same information at the same time. And each person has their own concern and their own personal view on everything. And so we don't mind doing that at all. We also offer online appointments. So wherever in the country people are that have access to data, we do Teams meetings. We don't often do Zoom anymore. We used to. But we've been indoctrinated into Teams now. So we're managing to use that. And if we're absolutely desperate, we also do WhatsApp video. So, it's not that we are not able to help people with counselling. We contact them somehow. And I think it's that information that patients feel more empowered when they leave our genetic counselling session, because they understand a lot more of the language, the medical language, the importance of the genetic testing and what it can and cannot tell us. So I think I'll end there. And if there are any questions, I'm happy to answer any of the audience has. Awesome, everything was perfect here.
Thank you so much. I think I learned a lot. I think as a clinician, you just don't have the information. We just don't know. Which is why we have to rely on you to order the correct test and to do the family counselling. I don't think we're always equipped to remotely answer what they want to know.
And I think also it's about when you're looking at the family, it's about asking the right questions to get the information that will be helpful
Yes.
to you.
Yeah.
Yeah. So, yeah.
So I think it was a wonderful presentation. I mean, I didn't realize that with prostate cancer, you can actually have the genetic mutation that can predispose you to other types of cancer. I
Yes.
actually didn't realize
Yeah.
how diverse. It's essentially everything.
Not quite.
But I mean, that's quite scary,
It is
actually.
scary.
Because you just assume, okay, prostate, male, inherited, yes, we know about that risk, but to have a breast or an ovarian CA in the family, that's interesting.
And colon cancers. So one of the problems with colon cancer when we're taking a family history is that often the patients don't know exactly where the cancer was. So they sort of motion to the stomach and they say stomach cancer.
Yeah.
And you always have to say, is it really stomach cancer or could it maybe be colorectal cancer? So, and then they're, I don't really know. And we ask them if it's possible for them to find out, but sometimes it's not.
Yeah.
So,
I mean, that is quite interesting because I'm just thinking of the number of patients I've seen. I mean, I'm not an oncologist, but I'm a hematologist. And sometimes your clinics overlap and you have to help the oncologist out.
Yes.
And I just wonder, because I wasn't there from the beginning, in their care, how many of them were actually encouraged to do a genetic?
yeah.
Because I don't recall that. Then also funding is an issue. So how much would it cost for a panel?
So it depends on which panel is appropriate. And if the patient is on an oncology program, then the local testing will come out of that.
Okay.
But if we feel, or if the patient feels that the overseas testing panel is more appropriate or will give more information, then that is an out-of-pocket cost. And the out-of-pocket cost for one of the laboratories that we use regularly is $349. So it's about 6,500 Rand-ish. And then there's obviously a courier fee for us because we send the whole blood over. And so there's a courier cost associated with that as well. And because what the laboratory overseas has done is that $349 is actually a direct patient cost. And that is why they've made it so reasonable. So I know with the exchange rate, it might not sound so reasonable, but compared with other genetic testing, if we had to Sanger sequence 12 genes on the prostate cancer panel, for example, Sanger sequencing of those 12 genes is enormously expensive, not affordable. If we put those 12 genes onto a panel and use NGS for sequencing, then yes, it's much more reasonable. But it's a panel that you have to physically combine. So you have to design it and compile it.
And you don't think the yield or the demand is enough to invest in NGS?
So at the moment, we haven't seen a lot of demand for prostate cancer genetics, but I do think it's coming.
And is it not because of lack of awareness? And I think that might be...
And hence the PhD in creating awareness and educating healthcare professionals.
And the local panel, the Oncomine panels?
Yes.
How much does it cost?
I don't know. I'm sorry, I didn't look it up. I didn't refresh. But I can find out. Maybe Michelle can. Thank you.
Because I'm just really thinking about the patients we've been seeing. And I wonder.
I think it all comes down to the doctor. Like you say, your PhD in educating. I mean, I didn't realize that genetic relationship, and I don't know if it wasn't known when I was training, or if they don't train us, or if
maybe it's a lack of awareness of whoever trained you. I do think that they probably did, but I also think that from what I understand from the medical training program is that it's such a small part because there's so much other information that you have to learn, right? And I think the genetics in per se is a really small part of the medical training program.
I mean, teach us the kind of basic concepts of genetics, but I think when it comes to the clinical application, in clinical practice, I don't think there's a very good.
I mean, I'm sure you remember autosomal dominant, autosomal recessive, all of those kind of things. Right. But it's about the interpretation of that. So, for example, exactly. So when it comes back to germline testing like this, we identify whichever gene, if there is a familial. And then we have to explain to the patient that, there's still a second hit, and that's why you only got an increased chance of getting a particular cancer. So it's not a definite chance that you will get cancer. And so for many of the genes, we do have risk values that will maybe be, like even some of the ovarian cancers will be a 30% increase. But if we look at a BRCA1 mutation, for example, I'm using mutation pathogenic variant interchangeably. If we look at a BRCA1, for example, or BRCA2, for example, the risk for a man to get breast cancer in the general population is less than 1%. And when they have got a BRCA2 mutation, then their risk goes up to about 10%. So it's a 10 times increase.
Yeah, significant.
And with prostate cancer, there's a double increase. So there's a double increase in the risk.
Yeah.
So it just depends whether you're male or female, whichever the cancer is that you are concerned about. And so we talk about the colon cancer, the prostate, the male breast cancer, the female breast cancer, the ovarian cancer, the endometrial cancer, all of the related kind of tissues have all got an increased risk depending on the gene and depending on the type of cancer.
And is it not maybe because of availability of testing that maybe we weren't quite, indoctrinated?
I think, from everyone must have gone through the NHLS kind of vibes, and there is not a lot of testing in terms of cancer. They do have a somatic cell unit at Joburg, which is the hematological kind of cancers, but I think for the solid tumors, I don't remember there being any training for myself personally, even going through all the genetics training. Even after I'd been trained, only then we started learning about breast cancer. I'm showing my age, but anyway, then we started learning about breast cancer and the potential genes that were related to causing the breast cancers. And there is, I think people always knew that there was a familial aspect to the cancers. And so therefore younger people were more aware in the family to maybe start screening earlier. But maybe they thought that that's the only thing available to them. And so now with next generation sequencing, being able to sequence a whole lot of genes at the same time is much cheaper, faster. And what happens with next generation sequencing, because it is a fast sequencing of the genes, what we do in our laboratory is that if there's a variant that we haven't seen before, we will then do confirmatory testing, use a Sanger sequencing, which is the gold standard. So Sanger sequencing basically means creating primers for either side of the actual mutation itself, and then sequencing just across where that mutation is. And so that is like a double check that what we are seeing in our NGS is true. Obviously, it's a common one, and we've seen it lots of times on NGS, then we're pretty sure that the NGS result is true. So it's about the technology also that you use in order to try and get to. So a lot with the hematological cancers, with break apart probes in fish, we've got the fusion probes in fish, we've got numerical probes, maybe there's trisomy 8, or like yesterday I saw a -7 in a couple of cells. So so it's all to do with where your breakpoints are, what chromosomes are involved, and therefore what the diagnosis and the prognosis is. So I didn't touch too much on the hematological stuff.
That's a huge.
Well, it is, and it's not my area of expertise.
So, Sarah, is there any role for gene therapy in those patients where variants have been detected and they are at a very high risk of developing that cancer?
So gene therapy, so what do you understand by gene therapy is the question. So is there gene therapy in terms of replacing a faulty gene? So think about the tissue itself. How are you going to replace the faulty gene in all of the cells in that tissue? And if it's an inherited type, how are you going to get to every single cell in the whole body, in the brain, in the big toe, in the heart muscle, everywhere, that you would have to replace that faulty gene? But I know that in some of the hematological cancers, and in some of the immunological diseases. A bone marrow transplant is found to be successful, but long term, we don't know, how long that gene therapy will last, whether it needs to be repeated, whether it increases longevity, by how much, we don't know. So there are different methods now coming in, as well as CRISPR-Cas9, which I'm sure you've all heard about. There are other methods of gene therapy that I started reading about a couple of weeks ago, but didn't quite understand yet.
Thank you so much. And thank you to everyone online. And good luck with your week.
Yeah.